We have our next speaker on tap. He is Dr. Daniel Culver. He is the director of interstitial lung disease of the interstitial lung disease program at Cleveland Clinic, and he's going to be talking about what have we learned about sarcoidosis lately and what may be next. So, Dr. Daniel Culver, please take it away.
Thank you for having me, and thank you very much for the invitation. Congratulations, Paula, and thank you, Pam, for this great moderating. It's wonderful that we have organizations like this that are moving the field forward, and really, it's without partnership that we won't get anywhere. So, I really appreciate what you all are doing in the space. This is going to be a very impractical talk. I'm going to talk about where I think things are going and some of the accomplishments that have happened. And I hope that what you'll take from this is a lot of excitement and enthusiasm, because I think the future is very bright. And I'm not sure I would have said that 20 years ago or 25 years ago when I first got into this space, but I think we're making tremendous progress now, and the advocacy work that you're all doing is a big part of that. So I'm going to talk about what's new in sarcoidosis. Here's the outline of my talk. I want to talk a little bit about the idea that this is a syndrome and not a single disease. This is a collection of diseases that all behave similar. Whether or not we're closer on getting a blood test for the diagnosis. I think one of the things that's held up research for a long time has been the absence of a model. Now we have some models, mouse models and other sorts of models. And then I'll talk about these last two topics, and especially about new drugs that I think are coming down the pike. Dr. Sharp will be talking about the general approach to treatment on a very practical level, and I'm sure this will be really helpful and great. But I want to preview the future a little bit first. We can call it Back to the Future. So the first thing about sarcoidosis as a syndrome, what causes it? Patients always ask me, what caused my sarcoidosis? And people could say, well, it was the Wicked Witch of the West. But really, I think that there's more than one trigger. And I think that many of us in the field have decided that perhaps the exact trigger is irrelevant. And really, we're talking about a black box that's the host, and that person has genes, epigenetic changes, host factors like obesity that's been shown in a lot of studies to be a risk factor, and modifier exposures. And then if you have a susceptible host, when you get that trigger, sarcoidosis happens. And maybe it's not a question of if, but rather when will that trigger happen. And then what happens afterwards? What's the pathway or the phenotype the patients are going to take? And again, that depends on that black box of genes, epigenetic changes, host factors, and exposures that modify whether this is in the heart or the lungs, whether it goes away or whether it persists, and the severity. So we think now sarcoidosis is probably not caused by one unique trigger, and I think a lot of the efforts around that have suggested there are more than one trigger around the world. So the diagnosis, I think, is always challenging, and people have estimated that it takes, on average, 6 months to diagnose pulmonary sarcoidosis. There are some data coming out, and this is confusing. I'm not going to go through this, suggesting that there may be the possibility of blood tests for sarcoidosis. I think these data are very preliminary, but these are data from the Wayne State Group looking at two proteins, cofilin and chain A. And what you can see in both Detroit, San Francisco, and in the Access cohort is that those dots are much higher than the black dots, which are patients without sarcoidosis. And this gives us the promise that there may be in the future blood tests that allow us to say who has sarcoidosis and who doesn't. This is not a blood test we can order right now. It's not something that's ready for prime time yet, but I think this is a direction you'll see the field moving, and I think this is going to help us think about how we can diagnose the disease without necessarily needing a biopsy. I mentioned before that one of the things that's held up research in sarcoidosis, and one of the reasons we don't have more drugs approved, is because we don't have a model where we can test drugs. When companies think about, do I want to study sarcoidosis or should I look at a different disease like multiple sclerosis or rheumatoid arthritis, they want to de-risk it. They want to be sure that their drug is going to work in something that's less expensive and easier to deal with than a human. So here's one model that's come out in the last decade. This is a group in Vienna, and on the left is just showing the normal lacy appearance of lungs. That's the top left. And on the bottom left, you can see these purple spots. These are clumps of granulomas in the lungs. This looks just like sarcoidosis. This is a mouse model of sarcoidosis, and you can see there the mouse has infiltration of its paws and its tail with these granulomas. This looks a lot like human sarcoidosis, and in fact, uh, um, Thomas Weikart in Vienna has used this with a lot of groups to help to study potential new targets for sarcoidosis. This has really got a lot of people interested in the field. So whether or not this is a perfect model doesn't matter. This is a doorway for research to happen. And if you look at this particular protein, which is called mTOR, there's a marker of it called PS6 on the top, phospho S6. And those circles there are granulomas, and the brown shows that the phospho S6 is indeed high in sarcoidosis granulomas. And if you divide sarcoidosis patients into those who are progressive versus those who are self-limiting, this kind of signaling that goes with this pathway is much worse in progressive patients than in self-limiting patients, suggesting that this has relevance to human disease. And I'll get back to that in a few minutes. We have other models. This is a model that Dr. Elliot Krauser developed at Ohio State, and I just focus your attention on the right side because this is looking at taking blood and taking blood cells and putting them into petri dishes, and then looking at how cells clump. And A and B show clumping of cells that looks just like the clumping of cells we see in sarcoidosis granulomas. And Elliott has used this in a lot of situations to also help study sarcoidosis and to help to look at new therapies. So this is really why you're starting to see a lot of therapies, potential candidates emerging in the field. And of course, as we talked about already with prednisone, this is what we all want. We all want therapies that can work well and not be toxic, especially like prednisone is. So these are exciting models, and I think they're stimulating or catalyzing acceleration in the field of sarcoidosis. So, what about personalized medicine? And personalized medicine just means, can we look at you as an individual and tell what's going to happen? Here's a cartoon that shows an example in cancer patients. And if you take a mixed group of patients, heterogeneous group of patients, and you study a drug in them, you see that some of them have a really positive effect. Some of them will have no effect, those are the blue, and some it will cause problems, those are the red. If you study them all together, you might both say the drug is ineffective, or if you're using the drug, you might be harming some people and hurting others, and it's really hard to tell which one is which. So personalized medicine allows us to say who's green, who's likely to end up blue, and who's likely to end up red or black here, and that will allow us then to be much more precise about what medicines we use and also to do our clinical trials in a much more reliable way. So personalized medicine really depends on measuring some things that we have in our body, DNA, RNA, and proteins. And I'll just review that for a minute. DNA really is the roadmap for how we are put together. DNA is then transcribed into RNA, mRNA, which is then used to make proteins. And our body is made of proteins. Proteins are the building blocks of the body. So what does this look like? You can think about DNA as like a recipe book. This is the thing you're born with. It's the recipe for how to make all the proteins in your body. And it's different than your sister. It's different than your brother. It's different than the person moving down the street. It's really the recipe that you're going to live with for the rest of your life. But recipe books are not static. You don't put a recipe book on your shelf and never mark in it. What you actually do is you mark it up and make notes and changes and highlights. Maybe you change it from a half a cup of sugar to 3/8 of a cup of sugar. These are called epigenetic changes. These are markers on our recipe book, on our DNA, which change through our life. This is why if you have a problem as a child, that thing may be likely to stay with you for the rest of your life. These are epigenetic changes, and we're learning more about how markers on the DNA change how our behavior is the rest of our life. RNA really is what we use to cook with. RNA is the recipe card. Nobody's carrying a thick recipe book around when they go in the kitchen. They use a recipe card and they use that to make the thing they're actually going to eat, which is the protein. That's the meal. That's what our bodies are made out of. Those are the proteins. So conventionally, we've studied all of these three things separately. People study DNA, people study RNA, people study proteins, and they don't talk to each other very well. Now we have technologies and people who actually put all these things together. As you can imagine, it's very complex, but it's also super powerful because you need to look at the whole picture. So if you look at a sarcoidosis granuloma on the left, that's a clump of all kinds of different cells. If you just mix those all together in a test tube like on the bottom and did what's called bulk analysis, you would get the average gene expression or the average proteins across all of those cells, and you wouldn't really be able to tell the relationships. If you separate those out using this new technique called single cell sequencing, you're able to get each individual cell type and look at its individual profile. This again lets us untangle much more precisely, like a precision medicine approach, what's going on in each particular individual cell, and to then start to look at pathways. How does this work? Here's an example where single cell sequencing in the skin allowed us to construct a map, that's what's on the left, of looking at a moderator called JAK-STAT and seeing some proteins that are JAK-STAT dependent and some that are independent. And you'll recognize some players on here like tumor necrosis factor. That's the target of infliximab and adalimumab, Remicade and Humira if you've used that. And so these are ways of thinking about what drugs might work. If you look at something that targets this JAK-STAT pathway, like a drug called tofacitinib, Bill Damsky demonstrated really nice effects in the skin. So this is a way that we can start to use new therapies in a way that's precise and scientific. I think it's really exciting. So let's talk about the next step in drug development. I made a list of some drugs that are available for treating granulomas or sarcoidosis. There's a lot of them. Here are drugs in red that I've actually used in practice. You could see most of them I've tried for various reasons. Some have been great and some have been not so great. But in fact, most of these haven't been studied very much. And if we look at the gold standard of studying drugs, the randomized controlled trial, the scientific study that really proves things work and takes placebo effect off of the table, there are much fewer that have even one randomized trial with more than 10 patients in it. Those are the red again. And if you take the bar one step higher and ask which one have been approved for sarcoidosis by the FDA, it's only prednisone and Acthar gel, and for the eyes, adalimumab or Humira. So we have a long way to go, and in fact, none of these drugs are sarcoidosis specific. So the question is, why are all these drugs borrowed from other diseases? Why are they repurposed? And the reason why is there's no obvious pathway yet for the FDA to approve drugs. The FDA doesn't really know what it wants to study or how to study it. And we're working hard to do that, but it's the science that's going to lead us to show what this pathway is. If you think about drug approval, it goes through various phases. And first, there's a science part, that's the microscope. I showed you that already. Then there are various phases that are increasingly large and increasingly expensive for sponsors to run. And at the end, there has to be FDA approval for you to get access to the medicine. So why should FDA approval be a goal? I would submit to you that the biggest reason why we need FDA approval is to treat you. The second biggest reason is once we have FDA approval, other industry sources will come into the space and we'll get a lot more funding, a lot more research, a lot more advocacy, and this disease will really get a lot of advancement based on people knowing that there's a potential to get a drug approved by FDA or the European Medical Agency. It's important when you think about clinical trials to recognize that there are a lot of stakeholders and they have different goals. There are companies or sponsors, there are patients, there are physicians. The financial people think about it differently. How big is the market? What's the profit going to look like? And the regulators think about it much differently than the rest of us. They want to be sure a drug is safe and that it's effective. And those things don't always line up. That's another barrier that we navigate as we go through these trials. So I want to just in the last 5 minutes share with you some of the latest evidence in clinical trials because I think it's exciting, and I would point out that there were very few trials done over the last 20 years, and that really a lot of these are happening now or just completed. And we'll talk about several of these: the EFZA-FIT trial, the XT-MAB16 trial, the Beacon trial, and the KITE trial, or KITE-1. The Resolve trial was recently reported, and that was a negative trial. I won't talk about that anymore, but I'll talk about the excitement of these particular trials. Now, you'll remember that I talked to you a little bit about how we look at the biology of the disease, and we look at the cells with the DNA, the RNA, and the protein. All of those things are part of the signaling that happens in the immune system. And if you think about signaling, it goes in steps, like these beacons. One signal goes to another signal, goes to another signal. And if you got the Lord of the Rings reference here, you get extra credit. But you could imagine that if you snuffed out one of these beacons using a drug or a protein, you might turn off that whole signaling cascade. So obviously, these beacons are very simplistic. It's just one line of beacons. In the immune system, it's much more complicated. Here's one signaling pathway called TYK2 signaling, and this is part of that JAK-STAT signaling pathway I told you about. And you can see there's a lot of complexity. There are a lot of players involved, and right away it gets really complex to think about, well, which one's the important one? How do I know which one to go after? And so that's part of the science that multi-omics stuff is helping us with. So on the TYK2 signaling, there's actually a very compelling trial. It's only out just right now in press release form. We haven't even seen the paper. And I thought that these beacons on the left were really apropos because it's called the Beacon trial. And this was using a JAK TYK2 inhibitor called brepocitinib for skin sarcoidosis. This is a trial that was done at 31 patients in 15 locations in the US. Patients, some of them got placebo, some of them got two different doses of brepocitinib. Some of you might have been in this trial, and if you were, thank you very much for doing it. And what this showed is that a marker of skin activity in sarcoidosis, the CSAMI, improved a lot. 22.3 points is a huge improvement in the CSAMI with the high dose of brepocitinib. And in fact, on the high dose of brepocitinib, 100% of the patients showed this really clinically meaningful improvement in the CSAMI. So this is something that we thought was going to be a useful pathway because of some of the science that came before. And sure enough, this really confirmed it. This will go on now to another larger trial, but I think this is the one that actually is really the closest and most ready to think about going for FDA approval over the next several years, this particular pathway. Here's another trial. This is the EFZA-FIT trial. And again, if you were involved in this, thank you very much. This is for lung sarcoidosis. And this took the idea that if we have patients on steroids and take them off of steroids, the patients on efzofitimide might do better and might have lower doses of steroids. And I think we can all agree that that's a really important endpoint. It's important to the patients. It's important to the physicians. We know that steroids cause massive toxicity over time. And so this blue triangle that's behind these three study arms is showing that patients started off on steroids and then they tapered that down up to week 12. And you're able to see that then for the next 36 weeks, patients were trying to stay all the way off of steroids. And so this took patients with pulmonary sarcoidosis who were on steroids, took them off the steroids, and it asked, did we get people off steroids more often using the efzofitimod? And the answer is no. It did show that 68% of the steroids could be taken away without patients getting meaningfully worse. And this graph on the left just shows that whether you were on placebo or efzofitimod, everybody got down from a baseline of around 10 milligrams of prednisone, that's an average, to around 3 milligrams of prednisone, regardless of whether you got the study drug. One take-home message from that is always talk to your doctor about, can we try reducing the steroids again? Maybe it'll work this time. You got to keep trying because this study shows you can get it down on average by 68% for a year with no problems. I think the really intriguing thing about this trial is that some markers of how patients felt, and KSQL means King Sarcoidosis Questionnaire Lung, got better in these patients who were on the study drug. And these yellow and gray bars show improvements in KSQ lung that started very early on in the study at week 4 and went on all the way to week 48, even more than the patients on placebo. So this is promising for efzofitimod, and it suggests to me that there's more to do here with efzofitimod. But I think the big take-home message from this is keep working those steroids down. Here's the third trial I want to talk to you about. This is called XTMAB16. This is an anti-TNF drug like infliximab or adalimumab, but it's made in Chinese hamster ovary cells. You don't actually get anything from Chinese hamsters when you get this, but when you make it in the ovary cells, and I didn't think you would like an ovary cell picture, so I just put a picture of a Chinese hamster here. These antibodies don't cause immune reactions like the other drugs do. And so this is perhaps a safer and more effective version. And if you take that Elliott-Krauser bead model that I showed you before and look at the right, you can see that the patients treated with, or the cells treated with XTMAB16 had much smaller granuloma size, and it looked a lot like how well steroids would work. So this is exciting, and this trial is ongoing right now. Last couple slides here. One is the KITE study. This is targeting an enzyme called chitinase 1, which is elevated and active in sarcoidosis and helps promote granulomas. You can see it's quite high in sarcoidosis. And I think the really cool thing about this study is this is testing people before they get on steroids. So this is testing them early on in the disease to see if we can make changes in their disease before they even get put on medicines like steroids that can be toxic. Last drug to talk about has a quiz. What is Rapa Nui? And in fact, this is the indigenous name for the Easter Islands. And the cool story about this is that when they discovered what was going on there, they realized that even though people walked around barefoot, there was almost no tetanus on the island. Tetanus is transmitted by a bacteria, and what they found is that there was a bacterium in the soil, a strep species actually, that makes a protein that blocks the growth of other microorganisms, and it's actually anti-inflammatory, and that's called rapamycin. That's used a lot for transplant patients, but it's probably also really effective for sarcoidosis. And studies are coming out with this. This is that mTOR story I showed you the skin picture for before. So this is originally from the Easter Islands, this whole idea. And if you look at skin sarcoidosis and just focus on this one on the bottom left, this is somebody who is on rapamycin or not on rapamycin with skin sarcoidosis, got treated, got dramatic improvements. And I think the really cool thing about this therapy is if you look at the green on the right, this is different than every other sarcoidosis drug we have. And I think this is tantalizing. These patients got better by this marker in the green after they finished treatment. What usually happens after you stop treatment for sarcoidosis? It comes back, doesn't it? In these patients followed out for almost a year, their sarcoidosis stayed away. So maybe, just maybe, and more studies have to happen, this is a drug that can change the course of sarcoidosis. This is a repurposed drug, by the way. This is not a novel drug just for sarcoidosis. So I'll just conclude by saying that repurposing is still the main pathway to getting drugs, but the science is really helping us know how to repurpose and what to prioritize. I think we are getting closer to a clear pathway for sarcoidosis, and I think your participation and advocacy is really important. We can only make this happen if people get involved in clinical trials. And I think that will open the door to other companies and the federal government and foundations getting much more involved. So I'll stop there and thank you very much for the opportunity to talk today.
Okay, thank you so much, Dr. Culver. I'm having trouble getting my picture up here, but let me just ask a question that was it came to mind when you were doing your presentation. Why Chinese mice? I mean, what's so specific about Chinese mice?
It's actually the Chinese hamsters. I don't, you have to ask somebody who's a better scientist than me, but It's actually ovary cells from Chinese hamsters,
Hamsters,
which can
yeah.
be grown over and over. And those particular cells, because of the way the proteins are made in those cells, they don't cause the human immune system to react to it. One of the big problems with infliximab or Remicade is that it's partially a mouse protein. It looks like a mouse protein to the immune system. And I think it's important for people to know that any biologic like infliximab or adalimumab, Humira, is made in a cell. It's not made by a chemical reaction. Cells make that. And so those cells make the protein, and then that protein is used for the medicine. And you're not getting a bacteria when you get that medicine. You're not getting Chinese hamster ovary cells, but you're getting the protein those cells made. And the protein made in those particular cells, for whatever reason, is really clean, and our human immune systems just don't pay attention to it. So it doesn't cause infusion reactions as much. It doesn't get rejected by the body as much. And the idea is that this will be a much more tolerable, more effective version of Remicade.
Hey, very good. Um, One other question that I'm seeing in the Q&A is, can you comment on studies looking at low dose naltrexone, NAI,
Naltrexone.
naltrexone in sarcoidosis?
Yeah, there's a lot of interest in naltrexone. It's certainly got anti-inflammatory properties, and it's got other properties as well. Um, I think that most of the studies about naltrexone are outside of sarcoidosis, and there are some larger studies and more experience with other inflammatory disorders. And it's similar to what we've done with a lot of other drugs. We borrow knowledge and information from other diseases. So I think those things make us enthusiastic about naltrexone. But so far, the overall studies that have been done in sarcoidosis have all been really small and hard to really feel confident about. And I want to just point out the reason why we do studies and the reason we want to be confident is there's a lot of ways to theoretically to attack sarcoidosis. There are many trials that have been negative that sounded great on paper. So until you really actually see it in patients and see that they're feeling better and that it's tolerable, we just get really we get anxious and it's kind of like show me the money, right? I want to see the data before I'm gonna really tell a patient you should try this.
Gotcha. Let me see. Somebody asked that they said that I saw that nicotine was listed as a medicine to treat sarcoidosis. Is that accurate?
It's not ready for prime time, but there are some interesting features of nicotine. This doesn't mean you should go smoke cigarettes. It doesn't mean you should do anything you can get at your CVS or Walgreens. But uh, this is again Elliot Krauser from Ohio State who really had this idea and drove this. And the idea is that nicotine can do something to cells in the immune system to promote T cells, lymphocyte cells, that can help turn down inflammation. And we worked with Elliot on that first study, and what we found is that when we gave people nicotine patches, that those T cells, those regulatory T cells, actually worked better after the nicotine. Now, whether that makes the sarcoidosis better, whether it makes it go away, whether it's sustainable, those are all open questions. But at least preliminarily, it's intriguing and it fits some other science.
Yeah. Okay, another question. Are you familiar with cortrophin gel?
Yeah, that's corticotrophin or repository corticotrophin is the broader umbrella name of Acthar gel. There are several different manufacturers or formulas for it out there right now. This was approved back in the 50s, and originally as a pituitary extract, and it has a lot of properties that overlap with steroids, but it's not the same as a steroid, and it has some other properties. And what we're not exactly sure about yet is how much of its benefit is driven by the steroid properties and how much of its benefit is driven by the not steroid properties. We know that some of the side effects of steroids seem to be better in patients taking it, and some of them are very similar. So I think there's more to learn on that one.
Yeah, and I have a question to myself. Who who is doing the most study? Who are, is it or is it universities? Is it drug companies? who's doing the most studies for sarcoidosis related treatments?
To be frank with you, most of the advances in treatment are from companies. The amount of NIH funding, especially over the last 18 months, has dramatically plummeted. And the NIH is not really set up to conduct clinical trials. Clinical trials cost several hundreds of millions of dollars. And so the way the companies work is they're publicly traded or they're privately supported by private equity, and they have to amass funds. They have to go out and raise money and then agree to spend, to give part of their potential profits to the people who invest. And so this is that figure I showed before. The financial people also have a skin in the game. And so companies are getting very interested in this. I think the more science and the better we understand that, the more interest we're going to see. Many of us work closely with them to help them think about priorities. I know there are a number of patients who also have worked closely with these companies, but they have the kind of pockets that allow them to really try something that is going to happen for you from a treatment standpoint. How do they know what to try? That's where the science comes in. That's where understanding the science, like the research labs in the universities and the NIH, really get that framework together so they know what drugs to try.
Gotcha. Thank you so much. Well, thank you, Dr. Culver. We appreciate all this helpful information. It's been very educational and informative, and thank you so much for being part of this session.
Thank you very much. Enjoy Dr.
Okay.
Sharp.
Okay. Thank you. Yes.